Good morning, everyone. Welcome to day 2. Don't you wish this was a whole week long? So I'm going to do something I forgot to do yesterday, and that is to introduce myself. So I am Dr. Michael Hayes, and it's my great fortune to be the director of the School of Public Health and Social Policy. And partly I say that just so that people watching online, if there are any, will know who their MC is for this morning. So just before we begin, we're going to follow the same format as yesterday. So we are somewhat time challenged. We did a fantastic job yesterday in managing time, and I anticipate we will be likewise today. I see in the audience 2 groups of people, those who are very relaxed and those who are perhaps a little less so. But you know, as we discussed yesterday, this is a very friendly audience, and it really is important to hone skills of being in public and as a professional talking about the work that you're doing. So we really do welcome this opportunity, and I have to say that yesterday I was just so impressed by the standard that you folks set, and I'm sure that that will continue today. So before we get to the formal presentations of students both in the MPH and our BA, and importantly in our diploma program, it is my great pleasure to introduce Dr. Damien Contandriopoulos. Damien is an associate professor at the University of Montreal, and we've had the great pleasure of having Damien and his partner, who is going to remain a secret to you, visit with us over the last year. So Damien has chosen the unprovocative title of Is the Canadian Medical Model or Medicare model politically viable? A particularly appropriate question, I think, for the times that we find ourselves in. Damien, welcome and thank you.
Hey, thanks a lot. First of all, thanks a lot, Michael, for inviting me today, and even more so for inviting me as an invited professor this year in Victoria, because it has been a marvelous day. And so I'm very grateful to be here. Yes, the title is a bit provocative, and does it mean something anyway? My talk is divided in roughly 4 sections. I will just present rapidly some figures about the current situation of the Medicare system as a whole in Canada, and I will choose example taken from 2 provinces, randomly chosen as Quebec and BC. And this will bring me to the second part of my talk, which is, what do I mean by politically viable? And here I just want to make something very clear. I'm totally convinced that technically the sustainability and viability of the Medicare system is obvious. There is no question that with the wealth we have, we can provide free, high-quality care to everyone. This is not what I'm talking about. I'm talking, can we actually do it? Which is slightly different, and I will make the distinction. The third part is about if we are serious about maintaining a performing healthcare system that we can afford and that is able to deliver high-quality care, what should be done? And I think there's some pretty hard to make changes that would need to be implemented in the next years. And finally, are we going to make it? And this brings me to my first disclaimer. I'm not exactly an optimist. Okay, so first of all, I'm from Quebec. So maybe there's a cultural thing there, but there's also Quebec being probably the worst province in terms of maintaining a functioning healthcare system. We're way ahead of the rest of Canada in terms of crumbling. And so this probably just, bias a little bit my optimism. But we'll see in the end if you do or don't share my level of enthusiasm regarding change. So what are the challenges? Well, Canada as a whole, is not exactly performing in terms of a few characteristics of the healthcare system. One that has been largely documented is the capacity to access good quality primary healthcare services. And this has been true in all provinces. In some, it's more acute than others. But if you look at the data, there have been numerous studies that aim to compare the accessibility of primary care services in Canada with other healthcare services around the world. We usually rank last unless the United States are included. So, and I don't have the time to enter in great detail about this, but when I'm talking about our primary care system, usually it's not that accessible. So if you're in need of services, you are likely to be either waiting for a long time, either going to walk-in clinics where the continuity and globality of the care provided may not be that good. And if you compare this situation with what's the current situation elsewhere in the world, well, we're not exactly a leading forefront. And there's an outstanding lecture that has been given last year at the CASPER being Conference on Healthcare Services in Canada. And there's each year a large lecture called the Emmett Hall Lecture. And last year it was Brian Hutchison giving the talk, Brian Hutchison being a scholar from McMaster. And he really had an incredible speech about documenting the current accessibility of the services. This is on YouTube, so if you want to watch it one day. But just to bring us back to performance, among the often quoted survey about quality of care, there is a group, left-wing think tank in the United States called the Commonwealth Fund. Commonwealth Fund does surveys with patients, with chronically ill patients, with doctors, with policymakers, and those surveys are always focused on the health system performance as a whole. And there's a little anecdote there. The Commonwealth Fund had that question, when you are in need of an appointment with your doctor, how long does it take between the time you call your doctor and the time you actually see someone? And they had that series of answers. So it was 1 day, 2 days, 3 days. And when they ran that survey in Canada, they had to have lots of options, like 1 week, 2 weeks, forever. And we are really different in terms of having access to a regular primary care provider. But this is the ranking, the most recent ranking from the Commonwealth Fund. It shows that basically in every single dimension, we're either last or just above the United States. So, and this is probably a curse in Canada. We are close by to the worst performing healthcare system in the world, being the United States. You probably know that quote from an ex-president of Mexico, "We're so far away from God and so close to the United States." And well, Mexico knows it for sure. And it does, and I will bring back, talk about this later on, about the fact that being so close to the United States drives up the price of our resources in healthcare, so it does have an influence on our system, but it also have an influence more insidious in the fact that we can always console ourselves, saying, well, we have Medicare, isn't that fantastic, because in the United States they don't have such a great system, which is true. But if you compare our system to mostly all Europe and to a large extent other systems around the world, well, we aren't that great, actually. And are we going in the right direction? There was a thing, and it was a post-Romano structure called the Canadian Health Council of Canada that has been dismantled since. And for a few years, that organism was following the reforms and performance of the healthcare system in all provinces except Quebec. And they have tried to see if we were actually implementing what was needed in order to improve the performance. Their last report has a very short summary on the first page, which is a decade of reform under health accords led to only modest improvements in healthcare, and the transformation we hoped for did not occur. It's time to refocus. So overall, it's probably fair to say that Canada doesn't have a high-performing healthcare system as a whole. It's not a catastrophe, but it's not high-performing, and we're globally not going in the right direction. So that's why I would say we're probably not we probably need to keep a little worry about the future. And this brings me to my second disclaimer. And as I said, I'm a health services researcher, almost full-time. So I've been documenting what's been going on in the last 10 years in Quebec. We are currently going very fast in the wrong direction, and we are faced with probably a crumbling of our Medicare, and probably Quebec opting out of Medicare in the next decade, unless there's a radical change. And does this matter? I think so, even for you, and I will come back to this later on. But for me, my stay in Victoria was full of surprises. Among those, seeing in the street signs, walk-in clinic, and not seeing a line in front of the clinic was a big surprise, because you won't see this in Quebec. In Quebec, you'll actually don't see a sign. They will try to hide the clinic somewhere so nobody knows about it. And even so, people will have to line up in front of the clinic. So there's definitely more access to primary care here than we have in Quebec. And there's quite a few different, so I spent a lot of time looking at the data, trying to make sense of both similitudes and differences between the healthcare system in BC and what we have in Quebec. Interesting thing, if you look at the overall expenditures, there are 3 provinces in Canada that are low spenders and that roughly spend the same amount on healthcare. Those are Quebec, Ontario, and BC. And also, those 3 provinces happen to be the 3 I know the most. And 3 provinces that are extremely different in their approach towards healthcare. So when you look at Quebec and BC, roughly, each person costs the same thing in terms of healthcare services. But when you look at the details, and there's lots of stuff here, and you see very different situations. So just to explain, those are dollars, and they're dollars in constant dollar. And all my slides, we're talking in constant dollar. This means dollar that have been adjusted to take into account the inflation, so the inflation doesn't skew the data. But if you see an increase, it's not about the cost of living increasing, it's about the real cost increasing. So those are the last 13 years of data from CAHI. And on the top, you'll see the hospital expenditures. Hospital expenditures are much higher in BC than they are in Quebec, and roughly growing at the same rate in both jurisdictions. Still, you could also almost complete the line. Like Quebec is currently where BC was 14 years ago in terms of how many dollars are spent in the hospital per person. Then there's that curve in the middle that you don't have in BC, or you don't seem to have, which is actually much lower. Those are drugs. In BC, you have that fantastic thing that's called the therapeutic initiatives. And over the last decade, lots of public effort has been put into controlling the unit price of drugs and making sure that you only prescribe drugs that have been proven effective. In Quebec, we have another approach, which is paying whatever amount the pharmaceutical industry charges us and prescribe anything randomly. And this second approach proved out to be slightly less efficient in controlling costs, so our drug costs are roughly twice those of BC, which is a huge difference. Then probably third curve, I won't discuss all of them in detail, but the third curve I think makes sense to discuss is that green line, which is physician compensation. How much money is invested in paying for physicians. And what you see in Quebec is a rapid and major increase in the amount we pay doctors. And it's a steady line, while in BC you have that very tight control over physician compensation. This is another thing that really characterized BC. 10 years ago, BC physicians were the highly paid physician in Canada and probably among the most well-paid physicians in the world. The amount invested in paid physician basically stayed the same over 10 years, which is a tremendous achievement. But it's also like a pressure cooker. Like you currently have been able to hold the pressure in the cooker, but it's boiling inside, definitely. And this will change. And then you have that mysterious red line, which is other institution. I've been trying my best to find someone who could explain me what are those mysterious and disappearing other institutions. I haven't found an answer, but if you do know, I would like to know, because those things are going extinct. It's maybe the last chance to study them before they totally disappear. And so I would be interested. But there's lots of dollar per person there, and it's going somewhere. Don't know where. Oh, and in Quebec, we're building hospitals. That's the last line on the bottom, that orange line. We are in the hospital building frenzy. There are currently 2 large-scale hospitals just in Montreal that are currently being built with a budget that is going to be blown away, but the official budget is $2 billion. So we're currently investing lots of money where obviously everyone in the world tells us it's a good idea not to invest money in. Okay. Still, beyond the difference, we have some similarities. And this is a slide that often draws lots of irritation from people in the system, but it's a rough measure of the resources you have in the system. And those are all the OECD countries, 30 so. And in blue you have the physician, in green you have the nurses, and in red you have the acute beds for 1,000 person. And so it's not a perfect measure of, the available resources to treat people, but still, it gives you a rough estimate, okay? And just to give you something to think about, under that yellow arrow, you have BC. And actually, I had to fudge a little bit the data because I included some non-acute beds for BC, because if I only included the acute beds according to CAHI, it didn't make sense at all. So actually, this is BC overstated. And who in the world does have less resources per capita than BC? Well, you have Israel, Mexico, Turkey, and Chile, which gives you a wide range of rich countries that, well, no, not really. And usually I was just trying to people were afraid of the fact that Quebec is here, quite further away, but still, below Quebec, you have Estonia, Portugal, Korea, Spain, Poland being above BC. In both situations, we have systems where there's few resources per capita. Remarkably few resources per capita. But then you should add another thing, and this is what makes this graph interesting, is to add the expenditures. So this gray line is the expenditure in every country. There's a huge debate about what is the best way to measure healthcare expenditure, or in fact any expenditure, and to be able to compare countries. The approach I've chosen here is as a percentage of the GDP. So a percentage of the wealth of the country that is invested in the healthcare sector. It's not the perfect measure. For example, if you're in a ridiculously rich country, Luxembourg, Norway, well, 10% of your GDP is a huge sum, which isn't the case if you're in a normal country. So there are biases, but it's probably the fairest measure of the overall expenditure. And, well, you have 4 spikes, like countries that do not behave like the other. Well, in fact, if you can find a relation between the amount of resources and the expenditure, they'll probably name a statistical test with your name on it. Because honestly, first of all, there doesn't seem to be any relation, not even an obvious linear correlation. It seems that you can invest whatever amount of your GDP and get an unrelated amount of resources, which is interesting. But still, 4 countries, 4 places stand out of the crowd. The biggest one is the United States, with roughly 18% of their GDP invested in health, which is a disaster. But then you have 3 other disasters. You have, just in the middle here, the average of Canada, which is above the rest of the world, but still not that bad. Then you have Quebec and BC, roughly at the same level, above 12%. And it's impressive to see places where There's so much money invested in healthcare, but so little resources available. And this is very simple in terms of economic terms. It means every single item will be expensive. Unit price to provide a service in those jurisdictions are very high. Those are places where you pay everything a very high price. We pay physician a very high price. Currently, I don't know if you know about that, but physicians are moving from the United States to Canada, especially Ontario, because it's more, you earn more in Ontario currently than you earn on average in the States as a physician. This may be contrary to what people think about the fact that the United States have unlimited amount of resources, but currently physicians were very, very well paid in Canada, probably second or third country that pays its physician the best, with the United States and Switzerland. Nurses in BC especially, are probably the highest paid nurses in the world. I'm not saying that it's a bad thing, first of all, because I'm an associate professor in the nursing faculty, so if I said so, I'd probably be looking for a new job. And as a society, it might make sense to decide to pay high prices in healthcare. For example, providing good working conditions, training, attracting and retaining skilled professionals, and so on, having access to new technologies. Maybe it makes sense, but still, it pressures a system toward an obligation to be high-performing. You cannot have very high unit prices and use them in a non-optimal way. Like some countries, like France, for example, pay its physician much less than Canada, and they have much more physicians. So overall, they spend the same amount of money on physician, but they can use them in a non-optimal way. You can have physicians randomly jumping around. We cannot do this here. It's way too expensive. So this is one very structuring constraint we have. And this term, I only have it for Quebec. I would say it probably makes the same, it's trending in the same direction, probably everywhere in Canada. And now the very powerful computers, they're able to do in economics what they call large-scale macromauling. So it means you take a whole population of several million person and you model their individual characteristic, age, revenue, work, and whatever, and you enter all this in a program and you try to see how this population will evolve over time and how it will influence the use of resources, the working condition, the work market, and so on. Okay, if we take Quebec's population and we see what will happen in the next 15 years, currently, the rate at which we invest money in healthcare is increasing at about, in Quebec, 2% per year. And I mean in constant dollars still. So every single year, we invest 2% more of our wealth in the healthcare system. And this looks like what's going on in Canada. In BC, it's slightly better. If we continue to do this, first postulate, and if, and this is a big if, and I will come back to this later, if we continue to treat the population according to the same structure of healthcare delivery, so we continue to treat people in high-tech, high hospital use kind of settings, and we have a population that is growing elderly, in 15 years, the amount of resources, of public resources devoted to paying the healthcare services will represent roughly 70% of the government's budget. 15 years, that's very, very short. And is it possible that the provincial government in Canada spends 70% of its resources in the healthcare sector? No, it's not. It won't happen, and the system will crumble way before that. Just before, because you need to have roads, you need to have schools, you need to have basic structure of the state, and you cannot provide all this with 30% of the income. Is it likely that the governments will rapidly and drastically increase taxes? Unlikely, for many reasons, both ideological and practical. So what this leaves us with? It leaves us with the fact that over the next 15 years, we'll have two possibilities, at least in Quebec. Either the system totally crumbles and is going to be replaced by something else. That something else is likely to be much more private, much less equitable, overall much more expensive. But it won't be paid through public money. It will be as mostly an American system is. This is option A. Option B, we take a sharp turn. We just move away from the current trend. And this won't be easy. And so, do we know what to do? Is it possible to move away from current trend? And this is where you have that distinction between the real technical sustainability of the Medicare system and what I call the political sustainability. Technically, can we provide better care, higher quality, more accessibility for less money than we currently are spending? Yes, we can. Is it realistic politically to implement this? Well, this is where the challenge is. It won't happen, and this is for sure, by just trying to control a budget cut approach. And this is one of my favorite graphs ever from CAHI meaning Canadian Institute of Health Information. And it probably exists in English somewhere on their website, it just wasn't able to source it. What this graph shows, it's the expenditure on health per person, and it's still constant dollars, since mostly the creation of Medicare in Canada until 2011. And what you see is a steady and linear rise. So every single year, Medicare was costing a little bit more. And that's just the natural structure of the system since its creation. So take into account that since its creation, that system grew steadily and linearly. And now we're saying this has to change. It's not natural. But then look at what happened. There's one glitch in that linearity. In the 90s, provincial government throughout Canada started to make huge deficits. There is that ideological shift toward right-wing governments. And all across Canada, we elected right-wing governments that decided to cut the spending in healthcare. How did they achieve this? They just cut the services and the amount paid to hospital and blah, blah, blah. And those were drastic cuts. And if you talk to any manager that was in office at that time, those were very rough times. But what happened is like trying to hold something that is moving and like acting like a spring. You can hold it for a while and hold it with all your might and hold it a bit more. And after a while, you're out of strength and you just give away. And where is that spring going to end up? Exactly where it would have been if you didn't hold it in the first place. And look at the expenditure. This is exactly what they have done. All those budget cuts were done exactly for nothing. Our expenditure grew back exactly where they would have been without budget cuts. So is it likely that we will control health expenditure by just saying we are going to control that budget very tightly and we're going to implement some, productivity improvement initiatives? No, it's not likely. It's very unlikely indeed. The changes I'm talking about will need to touch the basic structure of how we conceive healthcare, how we provide healthcare. And one of those ideas, what we call appropriateness. So making sure the right patient gets the right care by the right professional at the right time in the right setting. And as simple as it may seem, it's a huge challenge. When we're talking about appropriateness, there was that an outstanding study that has been done probably in 95 around so by Dr. Wright at UBC here in BC. And I don't know if, you probably weren't born in 95, but this is the time in Canada where what was on the media agenda and political agenda was the fact that people were waiting way too long for cataract surgery. So you had all those elderly patients waiting for cataract surgery several months, and this was so unfair. And it happened that at the same time the technology ophthalmologists were able to use would have allowed them to do much more, and there was a huge pressure on governments to make sure that they would pay more, to be able to treat more patients, and to improve the accessibility to cataract surgery. This is just one example, but that study in BC tried to assess how well did the patients see before the surgery and after the surgery. And since they rapidly almost doubled the number of surgery done, what the trend was that after they doubled the amount of surgery, roughly 30% of those patients waiting for surgery had an almost perfect vision before the surgery. And so after the surgery, their vision wasn't improved. Not only wasn't it improved, but for those 3% of patients that were unlucky enough to find a bad surgeon or were unlucky enough just to have a bad surgery, they were seeing their vision was impaired after the intervention. Those are huge figures. Like 30% of cataract surgery were medically non-necessary. Is this just a fluke? Aren't those more examples? Yes, there are plenty more examples of the fact that we are not using resources always in the best way. We are doing lots of intervention that have no clinical value, unproven clinical value, or very little clinical value. Especially we're investing a huge amount of money to extend the life, at the end of life, extend the life by a few weeks. And it may make sense in some situation, but in too many situations, nor the patient and its family are not benefiting in any way because those few weeks of extended life come at the price of a terrible quality of life. So there's some room for just spending the money wisely. And there, in terms of appropriateness, those data that comes from the United States regarding... Don't laugh, it's true. Okay? I don't know if you're aware of this, but since a few years, there have been a trend to lower the threshold at which we consider someone having a disease, and this has been done in several domains, including high prevalence chronic diseases, high cholesterol, high blood pressure, and diabetes. All those diseases, we lowered the threshold at which someone is considered to be clinically sick. And those researchers, very serious ones, decided to compute what percentage of the adult population in the US, and I would say it holds the same in Canada, what is the proportion of adults that are now clinically sick? And for people over 50, that's 97%. 97%, if you look at today's clinical standard, 97% of the people over 50 needs to take at least one daily drug. If we are in a society where we consider that being over 50 is clinically an illness and that this illness needs to be treated daily with expensive drugs, well, it's going to be awfully expensive. And it's the current situation. And then how strong is the evidence? Well, the evidence that if you have very high, for example, high blood pressure, drugs may save your life, the evidence there is unquestionable. But if you're close to the threshold, is there proof that you will benefit from the drug? There is currently no proof at all, except if you believe the drug industry representative, and we seem to do so, and it's turning out to be extremely expensive to do so. So we are in a society where we treat people on very large scale and often with very little proofs. The second part of the equation is changing the way we deliver care. Although we are in a jurisdiction with very few hospital beds and very careful use of hospital technology, we are still in societies where we're providing more high-tech, hospital-based healthcare per person than ever in history. And we are still in the trend where we are investing a little bit more of high-tech, high-cost intervention per person every single day. And it's not obvious that it's a good idea to do so. And is the primary care option of more primary care the solution? When, if you look at current investment in research in Canada, I don't know if you went to CIHR website, but it's all about primary care currently. We're all turning stir crazy, applying for primary care research grants. I'm too. And Is more primary care, better primary care, more accessibility in primary care the solution to control expenditures? Well, it depends. You can be on two different trajectories there. One is called the curve of doom, and we'll do more primary care. At the same time, we'll do more hospital care and more everything. And we'll just increase everything, so we'll do more of what you're currently doing and that's not working. So doing more of what's not working is definitely the best way to improve. This approach turns out to be not that successful in the human history, but we're still aiming our best. This curve won't bring us very far. The goal is, if we do more primary care, and we believe more primary care is a way to control expenditure and improve access to care, it will mean it's because we're doing less something else. And that doing less something else will be a huge challenge. Huge. Because as soon as you will try to shuffle resources away from some sectors, you can expect people to fight the fight of their life to preserve the status quo. And just politically think, closing a hospital, this is a politician nightmare. Something you really don't want to go through. People will mobilize, physician, community, the seniors, everyone will be picketing, save our hospital, and little children, sick children with, imagine the worst. But this is what will happen. This is the truth. So what would be the solution to just change a trajectory? More primary care without investing way too much resources imply having primary care structures that are more coordinated, more local, more interprofessional. This means you'll have a lower physician ratio in teams, and in many situations you can have teams where you have one physician and 4 other professionals, and probably that means 2 registered nurses, maybe 1 nurse practitioner and 1 social worker. This looks like, and physician, primary care physician, this looks like a small high-performing team, because every single professional will be able to use the full scope of what he or she is able to do, able to deliver, and you will have more care per dollar than you currently have in a high physician intensity system. You stop paying people mostly fee-for-service. You'll need to implement other way to pay them. If you continue to pay physician only fee-for-service in primary care, don't expect them ever to work in interprofessional team. Every time they will try to work with someone else, non-physician, they lose money. And, physician can be all well-intentioned, good people, caring individual, but just cutting your own income every single day you come to work, that's a lot of demand for any human being. So just don't try to put the incentive where they shouldn't be. You need to implement that kind of change. You think that you need to take appropriateness seriously. I don't know if you have seen that. Maybe how long do I still have?
About 8 minutes.
Okay. Have you witnessed that huge mammography debate? Mammography data, a very strong Canadian study. The last series of results have been made public recently show that mammography on a large scale is useless. It won't prevent any additional death. It won't prevent any more cancer than regular care without mammography by a physician. And that study just duplicates what has been the result of almost any serious study on mammography for one, but on many large-scale screening tests. Prostate cancer is one, coloscopy is another. So very strong evidence suggests that it's pointless to pay or to expose a large population to those tests as they do not provide any improvement. But have you witnessed in the media the reaction of the radiologists? They just went tear crazy. This isn't good science, it's not serious, come on. And then they take their strongest evidence. Last week I saved the life of one of my patients. And this is the current way we are assessing how we invest money. On the one hand, you have very strong evidence that has been double-checked, peer-reviewed, and that has been duplicated. This evidence shows it's useless to do mammography. Well, we disregard that evidence. On the other side, we have one radiologist that claims that maybe he saved one patient sometimes. This is strong evidence. We should continue to fund mammography because it's great, great technology. And this is where it won't be easy, and I will come back to this. Aligned physician in the hospital and financial incentives. In BC, there have been some changes there. More and more hospitals are paid in a small part, but significant part, on a volume basis. So every time a patient is treated, this amounts to a little extra money for the hospital. But if you look Canada as a whole, historically what we have been doing is fixed budget for hospital and fee-for-service for physician. So physicians want to treat more patients because that's more money for them. Hospital want to treat less patients because they want to hold their budget tight. And this just have proven to be very. You have hospital with two heads. Physicians do their best to do something that the hospital does it best to prevent. And the two-headed hospital is a creature that isn't likely to survive on the long-term natural selection terms. And have strong information system. In Africa, they're doing vaccination on children. UNICEF is doing it. They have things that look like iPads that they can fingerprint the children they're vaccinating, and they can just know if a children has been vaccinated in the future. They're doing it currently in Africa. Is there any single way to know if a kid is vaccinated in BC? No, there isn't, nor anywhere else in Canada for that matter. They're just that tiny piece of paper that most families have lost in the past and may have found out and may have stapled a few of the vaccination information. And this is supposed to be our best piece of evidence regarding the vaccination rate. Well, it's not exactly considered as super high-tech in terms of technology. Are we using currently information system that allow nurses, physicians, when they're providing care, to have access to direct information so they can enter information in the system, and that information is used by manager in the system, and they're getting something from the system. I'm prescribing a drug, I enter it in the computer tells me, well, doctor, have you checked that this patient doesn't have this and this condition? Because if he does, you may not use that drug. Doesn't change the liberty of the physician to prescribe, it just reminds him, and such systems do exist. Are we leading the way in Canada? No, currently we're probably among the least developed country in the use of those technology when you look at rich countries, so we need to get serious about this. This is the road that we are following in Quebec. We are driving high speed straight ahead. And my opinion is that it's not a good idea. I would say it's probably time to take a turn, and it's not about knowing the technical solutions. Technical solutions to improve quality, performance, better control of the costs are known. They are proven to be effective. They are well studied. It's not about knowing what to do. It's about being able to do it. And this is a political challenge. It's not a technical challenge, but you should not underestimate the political challenge. Probably the most well-known health economist in Canada is at UBC. He's called Bob Evans. He published alone probably more than half of the rest of the health services researcher in Canada. And he's always keen to bring back the fact that someone's expenditures are always someone else's income. And so, if you want to shift resources from one sector to another, someone will lose, and that someone won't be happy about that. And there's going to be very difficult fight there. It's not going to be easy, and those fights are going to be fighted in the public arena. They're going to be fighted in the media. They're going to be fighted in demonstration outside of hospital. And in those fights, when you look at governments in Canada, they have proven to be both very weak and very ill-equipped. They usually have been only very bad answers when there has been a growing discontent to maintain the status quo. So there's something that will need to be done to improve the political capacity of governments throughout Canada to just propose, implement, and be able to get through with the changes that need to be done. There are some very large-scale systemic cost drivers. When I say everyone over 50 is sick, technically, this is not something that we can control in Canada. This is a worldwide trend. We have new technology that turn out to be extremely expensive, and those choices are also going to be extremely tough, both when the technology is proven to be effective. Currently, hepatitis C is a huge public health challenge. Current drugs are expensive and not working that well, but the new drugs that are coming on the market, there has been discovery recently. There is a new drug coming on the market with much more efficiency to treat hepatitis C. The cost is $200,000 per person per year. But this is an effective one, so it's a real challenge. Are we going to fund this, and how? But then you also have all those interventions that prove out to be extremely expensive, for which we don't have any evidence. Cancer drugs. Always new cancer drug going out, usually with almost no evidence whether they work or not, but the physicians are prescribing because they're dealing with dying patients, and we're just spending lots of money there. There's lots of technology that just happen to be there. And how are you going to explain to a specialist physician in his hospital that on the just other city, they do have that new high-tech fancy machine that does beep beep, and he doesn't have that machine, and that's totally unacceptable. In Montreal, a pediatric hospital I went to, they told us, do we want to participate in a trial to calibrate their new bone density machine? And so I tried to understand what the thing was, and they say, well, we have a new bone density measuring machine, and those machines are calibrated for adults, especially elderly adults, but we have no clue whatsoever what's supposed to be the normal bone density for a kid. So we need healthy kids to pass them through our machine to know what's the normal bone density is. And then I made some research, and it happens to be that there's no problem related with bone density in children whatsoever, but they have the machine, so now they need to process kids through that machine so they can just do something with that. And don't laugh, because currently we have plenty of machines. Do you know Monty Python's, the machine that does beep beep? Well, it's not even a joke. Yeah. And healthcare culturally occupies a very special position, especially physician. As I say, look at BC physician. Those are physicians that their income did not increase significantly over the last years, when all other physicians in Canada had their income increase very rapidly. Take Quebec, 10% increase per year for the last 7 years. It's that pressure cooker, and it's currently very high pressure. And how are we going to control those trends? This is going to be a challenge, especially so in a society where physicians really have a special position. When you look at the credibility of physicians going in the media and saying, we need that new technology, we need that machine, I need to treat my patient. Watch out for this. And watch out especially because in several situations, Quebec currently is exactly there. Specialized physicians have made the conclusion, at least their union has made the conclusion, that there will be no more public money. We have just saturated the government capacity to fund more specialized services. So their strategy, and they're very open with it, is we need to privatize the system, at least partly, so we will keep all that public income, and we will top this with some private income. And this is the strategy. They're transparent about it. And look at your very own Dr. Day. The trial is going to open next year, and those people are well-funded, very serious, and they do have an agenda. And that agenda is that you could increase the total expenditure on health by opening the system to more private care. Citizen will just pay more. Who cares? They will earn more. So That's what the thing. And does it matter that Quebec system crumbles? Yes, it does, even for you, and even if you're very far away, because as soon as Quebec system will have crumbled, and this is soon enough, all those advocates for private healthcare in BC will just be enthusiastic about this can be achieved. We nailed one, 9 to go. Thanks.
Damien, thank you very much for a very powerful start to a Friday morning. There is lots to think about here, obviously. Unfortunately, we're just a little bit time challenged, so I'm not going to ask for questions. Sorry. But Damien, will you be able to join us for the rest of the morning?
Part of the morning.
Part of the morning. Yeah. So you might be able to grab Damien at the break if you have a question that you'd like to explore. But again, on behalf of us all, Damien, thank you very much. There's so much in what you've said, and I won't try to rehearse it all. Okay, so folks, just as a reminder, when we start a session, if you're a speaker in that session, if you wouldn't mind just maybe getting yourself ready by sitting down here, really would appreciate that, because that would just help us to manage the flow. And while we're setting up, I guess just a couple of things that really struck me out of what Damien was saying is, first of all, we don't really have a very good discourse around death in this country, actually. And that's part of what fuels that whole imperative around asking for more, right? I mean, you think about all the faint hope clauses that are around advanced disease directives and cancer treatment and so forth. We just don't have a discourse that says, hey, can we accept death and let it go and let people create sort of family relationships, tie up loose ends and so forth before they exit the world? Because one of the things that I think, if empirical evidence tells us anything, we ain't getting out of this world alive. So